Good afternoon and happy Friday. Today is May 29th, 2020. It's 1 p.m. Pacific time, and this is the CAF COVID Weekly Roundup. I want to thank you guys for joining us. Gosh, I look forward to the day when my Fridays are not filled with doing webinars for you guys, and we can finish this thing. But unfortunately, I don't think that's anytime soon. So we'll continue to do these for as long as necessary. Our hope is that the flow of AFLs and guidance documents will slow down. It kind of seems like we're getting to a more stable place in terms of the guidance that's coming out from the state and things like that. So, and then we have a guest speaker today, Brian Rivera from Tampico Terrace Care Center. They're located in Contra Costa County. And then, of course, there's a link there if you have questions about any of our coronavirus toolkits, or if you want to find a listing of all the AFLs or guidance documents from the CDC or information from CMS. We collate that and put it all into one page. So I want to direct you guys to that, especially if you're looking to backfill information that's going to help you build your mitigation plan. A lot of those guidance documents are listed on the website. All right, so we talked about testing last week, what we thought was likely to happen. That testing AFL came out 8 o'clock at night on Friday, but it essentially went over most of the stuff we talked about last week, but we're going to dive into that a little bit deeper because I know this is a huge issue for folks. And then just wanted to call your attention to an AFL that went out regarding a heat advisory. And I understand that this is like, so far down on the list of things maybe that you're paying attention to. But as the reason why I bring this up is I've had a couple of providers call me and ask me, look, my facility does not get cool that well in the summer, and we're experiencing, well, now today's great, but the last few days we've had triple-digit heats in the Central Valley and maybe other parts of the state. And how do you move air around and keep folks cool when we know that at least some portion of this virus could be moved around if we're moving air in our building? So some of the discussion has been, well, if you've got a COVID unit and you're hooking fans up to cool people off, whatever you do, we don't want that air being pushed from the dirty side to the clean side. And I use dirty, that's really, it's just an easy way for you to think about it. But as you set these spaces up, and when we're looking at, doing this throughout the summer or maybe even longer, think about how you're moving that air around, because you definitely don't want to push it to the side that you're not cohorting folks that have COVID or are suspected COVID. I don't know this for a fact, but I think like those personal fans hooked at the head of a bed that push air down the resident's body may be okay because they're not moving a lot of air. If you're keeping the door closed, it's giving the chance to your HVAC system to circulate the air around the room. That's probably okay, but I can't give you specifics. But I just want you to be cognizant of that if you're setting up portable ACs or fans and things like that. We just don't want that air being pushed towards the side where folks are either not wearing PPE or they're not COVID positive. So, and if you have questions about that, certainly give me a call and we can work through it and try to find a solution for you guys. So we had there's a college called Laney College located, I believe they're in Alameda County, and Laney College, the students at Laney College in their manufacturing program decided to take up a challenge of and created a GoFundMe page to get the materials, and then the college students started building face shields. Now, we're asking that if you're in dire need of face shields and you need the face shields donated, these folks may be able to assist you. Face shields are meant to be reusable, so don't ask them for 1,000 face shields. Be reasonable. They want to kind of spread this out to facilities that are maybe in rural or underserved communities. So if you represent one of those two provider groups, reach out to those folks and see if they can help you out. And then I wanted to talk about the video project that we want to do. And frankly, I think we've had this idea of being able to do it. It's just that dedicating the time and finding the volunteers to be able to do it. But we see all of this negative press, and the tide has turned some. And I talk to enough media members, and Deb Pacina talks to enough media members. We all do, to try to get our experience and let folks know all of the difficulties, the frustrations, that casting blame to skilled nursing facilities is unfair, and here's why. Sometimes that's really effective, and it's certainly very effective when we message that to the to the policymakers and things like that. They have an ability to see both sides of the argument. Folks in the public may not, and so as a way to possibly turn the tide of public perception about what happens in skilled nursing, I would love, and I think we would all love, is to have a video project similar to a documentary style interview where we could talk about your experiences. And we don't need to even keep this to folks that have dealt with COVID. I mean, we want to capture information, even if you've not been impacted in terms of a COVID positive person in your building. What are the experiences of having to deal with keeping your staff morale up, and dealing with the extra expenditures and things like that? So the goal for this is we'll develop a scripted series of questions that are designed to really kind of capture the experience. We're going to do this and edit it all within CAT. So let's just say if you're hesitant to get on a recorded audio or video to talk about your experience, we will edit out what you feel uncomfortable with. And certainly our goal is not to point out flaws in something that you think you've done. We'll leave that for afterwards, but we want people to understand the experience, the impact that it's had on you, on your staff, on your ability to provide services, healthcare services to these folks, not just now, but going forward. We don't necessarily need administrators to talk about that experience either. Ideally, we want somebody that's comfortable doing a video Zoom kind of interview so that we can give that face. I realize if you're not comfortable with that, maybe we can talk about answering some questions just with audio. But still, I think to make this as impactful, to make this as so that people get a flavor of this in a manner in which it's not limited by a soundbite. I think that's important, because even when I talk to the media or Deb talks to the media, I could talk to them for an hour straight, and they use 2 lines of what I said in our interview. So that doesn't tell the story. So what we want to do is give you a forum for that, a voice that's not constrained by a specific message that we want to pass along. So, and generally when you talk to the media has an idea of where they want the story to go prior to asking for your input. And so what they ask and what they use from you may be very limited. So it may not tell the true story of what's going on in our building. So We will set up, we're gonna set up all this stuff. If you guys have anybody, staff, DSDs, DONs, infection preventionists, if you have a story to tell, we want to get that on camera. So please ask your staff if they're comfortable to do it. If you're an administrator and you're comfortable doing it, if you're an owner and you're comfortable doing it, this is the only method that I know of that we're going to be able to get an unfiltered description of what's going on in your building from you guys. If we don't do it this way, the story's going to be told by other folks, and we just need to get ahead of this. This is going to be a long-term issue for our industry, and we want folks to know how hard you are working in your buildings every single day. All right, so let's move to the testing, and I use the air quotes. I'm using air quotes around recommendations. Even though the AFL has clearly said that these are the recommended, this is the recommended guidance for adding testing to your mitigation plan, we don't think it's likely that if your testing plan said, I'm not going to test anybody, and you submitted that, would they accept it? So then it really can't be called a recommendation. The question is more, what are they mandating? We'll jump over that hoop when we get to it, and I'll ask you guys for feedback on what was the result of your mitigation plan review. But before we get to that, let's talk about what the expectation is. Baseline testing, that's everybody in the building. And I will say that not every county is going to follow lockstep with the CDPH guidance. Some are going to be more conservative. In counties where they're less conservative, they may stay with that, but based on the feedback that I see from Los Angeles, I don't know that that's going to happen. In Los Angeles, 2 days or Wednesday or Tuesday, they submitted a checklist to go with your mitigation plan, and it had some suggestions on the testing at 10% of residents and staff weekly. Yesterday, Dr. Farrar, the health officer for Los Angeles County, said that they were going to go to the state recommendation, which is, we'll get to that in a second. But my point is that you may have a plan that's integrated with your local health department. I gave a piece of advice, and I think this is probably accurate. If your local health department is still unsure of what the kind of targeted goal is for baseline or for surveillance testing, build that flexibility into your plan, or at least when you do your plan review with a person from the licensing, you want to tell them, look, hey, this is what our local health department is telling us to do. We're going to follow that guidance. If it changes, we'll change ours. And I think that's probably, if you're in a county that's not going to do the state guidance, that's probably what you're going to have to do. I think public pressure will probably force these counties that aren't doing that to switch to the state recommendation or to something even more conservative. So, and let's talk for a second about, so the recommendation, I don't think the recommendation to do a baseline test, I think that's going to apply statewide. It's the surveillance testing that we still have tons of questions about. The testing of admissions and readmissions. This came up on the HAI call that many of you guys I know are on yesterday, I think Thursdays at noon, or maybe Wednesdays. I lose track of the day now, but they had essentially admitted that the hospitals are not required to test when they discharge. It's recommended that they test prior to the discharge to the SNF. And whoever that was that asked that question of Heidi repeatedly yesterday, thank you. Thank you, thank you, thank you. It seems like it's one of the two primary vectors for COVID to be introduced into our building. We think it's silly that you require the test once they get to our building and not require the test of the hospital that has the test kits and the ability to test right there. So we continue to advocate for that. We have conversations with the hospital association to ask them to tell their member hospitals to please, please, please test every admission into a skilled nursing facility. Until that time, CDPH on that call yesterday said that you're going to have to set these folks up into a transitional space and observe them for a set period of time until you can confirm they're negative or they're positive, and go from there. I don't know that this is probably going to back up hospital admissions. And there's also language in that AFL that says, quote unquote, quarantine. Well, quarantine has a pretty narrow definition. And I think really what they're looking for is that transitional space. I reached out to Heidi and I brought that language up on the AFL and thought it's possible that this could be misinterpreted by the field staff saying that each facility needs to have a quarantine space, meaning a single room with a single bath for all admissions. I'm hopeful that well, maybe I shouldn't hope. Let's just think realistically, some people may have an issue with that. And I'm hopeful that they could at least adjust the AFL. But until that time, if you have somebody reviewing your mitigation plan and they're saying, oh, hey, why have you not set up a quarantine room? Please let us know so that we can address it specifically with the district office there. We're going to test all symptomatic people. And then that, if anybody becomes symptomatic, we're going to process the test and then go back to, and if one or more of these people turn positive, we're going to restart over and do baseline testing for everybody. That's spelled out in the AFL. I honestly don't have any issues with the clinical guidance of how that works. It's very consistent with what we've seen in other states of best practice for managing an outbreak in a skilled nursing facility. So in terms of their goals and things like that, it's not like they're not well thought out. It's just that we've not figured out virtually any of the logistical or operational challenges. So, and we're going to get to that in a second here. So, but as far as the goal and the guidance and what they want done from everybody, I don't think that's unreasonable, to be honest. So the problem is, how are we going to do it? I know many of you guys have already begun the process of contracting with labs. The link there is to the testing task force website, and that PDF is the most current version of the testing labs. But this is updated, gosh, almost daily or every couple days. From the first time they sent that out, I had 2 labs on it, and now it's 15 or 20. So there's more labs being added to this every day. So if you're looking for, if you click on the link, it has basically 3 categories. Is it just a lab? Is it a lab with distribution capacity? Or is it a full service provider? And so full service means they come bring everything to you. They bring the personnel, the testing kit, everything. They do the testing, they send it to the lab, they process it, they give you the results. That's the full service. The distribution companies will send you the test kits, have you do the test collection, and then send those back to the same company. They read the labs, they give you the results. So those are kind of the 2 methods you can go through, and we'll talk about that. And then there's, I want to talk about the mixed messages from folks. I know that it's quite often that CDPH talks about collaboration and working through this and being a partner. But I've said this before, and I want to be clear. CDPH's goal is the life safety of the residents in the building. If that aligns with your business, that's great. If it doesn't, it takes a back seat to the protection of the life safety of the residents. So when we talk about things, we want to bring ideas up to the CDPH to let them know that financial viability of you as a business is important, because this is not a short-term solution. And if we hammer you with costs over and over and over again, we're going to take that portion of the healthcare out of the healthcare system. And I just want you to understand that. And when I say really they want us to be self-sufficient, it's nobody at CDPH is waiting to ride in on a white horse and save the industry. I just don't think they feel that's in their purview. And their purview, at least from the licensing side, is to create guidance that folks have to follow based on best practice. Not much else other than that. Coordinating counties to have a consistent message. Coordination of response does not appear to be in what they're going to do. So when we think about that going forward, we're on an island, but the island is not empty. It's not you by yourself. And we're going to talk about that in a second. I think Brian's got some good information about that. So, but I just want to set that expectation for you guys. They're limited in what they're going to do in terms of helping to meet this testing testing recommendation. So as we go on and talk about the surveillance testing, the surveillance testing is going to apply to everyone not already tested, obviously, but also 25% of staff weekly, 100% of staff monthly. Some counties we know are trying to go to an even shorter time than that. Santa Clara comes to mind. They have every 2 weeks, 100% of staff do it. Santa Clara is managing it pretty much internally within the county, whereas they're giving the test kits to the providers are doing the tests and driving them to the lab at Stanford and then getting the results in 24 to 48 hours. Ideally, that's what we'd love to see every local health department do. The reality is not everybody has the resources that Santa Clara County has. There's a few that do, and they're mostly confined to Southern California or the Bay Area. And for those areas, it may be possible for the local health departments to fully and internally handle this testing thing. But I don't want you to rely on that, because I don't know that that is sustainable for them. And when we talk about testing of staff, this is probably going to be a long-term thing for a while. We're not, we're in stage 2 openings in most parts of the state. Pretty soon we're going to go to stage 3. What does that look like? Well, that looks like accelerated exposure for our healthcare workers that are now out in the community. So there will be a longer term vision for how this happens. And so when we talk about doing that testing, if your local health department is going to manage it and do it all for you internally, oh, you are a lucky camper. The rest of the folks, I don't think that that's going to be an option. And we've talked to a number of counties. I don't want to call them out because I want to give them a chance to try to change their focus and make this a priority to them. But it definitely is, all of us should be prepared if the county no longer can sustain that, to be able to do the testing ourselves. So that just means the capacity. We'll get into the billing thing in a little bit. That's a whole another ball of wax. So, and then what do we do with refusals? We've got a number of folks that have mentioned that they have had staff refuse to take the test. And then when they were asked to work the COVID positive side, they declined. And CDPH has said that as an employer, you have a right to fire that person. but there's complications. If you're a union building, I don't know if that's allowed in collective bargaining. I'm not an attorney, but really what this is going to make you think about is to ask if you have a labor law attorney that you normally deal with, you're going to have to ask them. We've reached out to a couple of law firms that deal with employer rights and things like that to ask them what happens if somebody refuses. But I think the guidance from CDPH is, if you refuse, then you're to work with the COVID positives. If you refuse to work the COVID positive unit, then you should be fired. That's essentially what CDPH said to us. Now, I don't know if that's legal or not. You're going to have to find that out. And if you have a union and you have collective bargaining, that may not be allowed. I don't know. So, but there's still more you're going to have to look up with that. I heard them talk on the call yesterday that nobody's going to want to do this, but 100% is pretty hard to get. So we know somebody's going to refuse for whatever reason, valid or invalid. Data collection. We don't have a lot of information on how they want this data submitted other than to the district office. But I think a big portion of how you do this testing is going to really rely on data collection. It almost feels like a full-time position to be able to manage this, on an ongoing basis. And then the communication, we've talked about that, I think on the last webinar, but the communication with the families and with your staff will help ease a lot of the issues that you do see. I do agree with Dr. Westman when he says the better we are at communicating with our staff about what's going on, is more likely that they'll feel engaged in helping us meet the challenge. Serial retesting was also a part of that. That's a whole ball of wax if you discover an outbreak. And if you have questions about that, we can go over it. I'm not going to cover the staff shortages just because I went a little bit longer, and I want to talk about the billing and kind of what can happen before we go forward. So we know what the cohorting recommendations are. We changed our mitigation plan slightly to align with what they were calling the 3 categories, but we didn't make any material changes about what we would recommend in those cohorting categories. And then staff, 1 positive, retest every 7 days, but they can work as long as they're assigned to work in the COVID positive unit. All right, so for the coming weeks, I talked about long-term planning. The hospitals are going to start moving to reopening for elective procedures and things of that nature. We're going to get more discharges from the hospitals as the next weeks and months go along. Those folks are probably, and depending on the hospital, we're probably still going to have a problem getting those folks tested in any kind of reliable manner unless CDPH or a local health department makes it a health order. So when we talk about long-term planning, we have to understand that those folks that are going to come from the hospitals that have kind of trickled out, they're going to start coming at a greater rate. And that's fine if you want to say, look, I'm not going to take any discharges right now or whatever. I suppose that's your choice, but I don't know that that's it's a financially sustainable model. I think that we need residents to be able to pay the bills. So we need to have a planning process for making sure that we can do this on an ongoing basis. And then capturing and documenting costs is gonna be huge. When we talk about this testing, the number one question is, how the heck are we going to pay for this? We know that CDPH has told us that this is a covered benefit on everybody's health insurance. And I go, oh, well, that's great. Do we send them to their doctor, or do we order the tests like a doctor's office and provide the tests and then send them to a lab that we have a contract with, get the results back, and then send bills to each one of the health insurance plans like we're a doctor's office? I mean, I'm throwing that out there because I don't know. And on Wednesday morning, they essentially told us, you're going to have to figure it out. You're an individual business owner, and you're going to have to figure out how to get this testing done. It was not a very comforting or warm conversation with them. So if folks are doing this and they have a method of making sure that the cost of staff testing is recovered or at least offset by individual health plans, please let me know. We want to build a model that works for everybody. And then in counties where the local health department either won't or does not have the capacity to do the testing for you, it doesn't absolve you of the responsibility to do the testing. Sadly, that is exactly what they said on our call with them Wednesday. So, and then when we get to the meeting, you know, and the mitigation plans, many of you have sent them in already, but as you, when you send them in, we expect that you're going to get a process in-person visit in approximately 6 weeks, and then every 6 weeks after that to review the mitigation plan you submitted, as well as review your compliance with the mitigation plan that you've submitted. We're going to need lots of feedback on this because we anticipate a huge variance across district offices. And the only way we're going to be able to track and give feedback to the state is if you let us know when and how those problems are arising and what the nature of the problems are. We'll be happy to address those issues with headquarters if and when we get them. So I talked for a half hour straight. I apologize for that. I know folks get tired of hearing my voice. But I want to introduce you to Brian Rivera. I've known Brian for since I've been at CAF. Brian has been coming to our classes, whether it be OSHWAT or life safety or emergency preparedness. And I just wanted to bring Brian on. When this whole thing started, we originally sent out a survey asking folks to volunteer. Are they willing to dedicate a portion or all of their building as a COVID positive receiving spot? And not unsurprisingly, not a lot of people raised their hands, but one of the first people that did and was all in was Brian and his team at Tampico Terrace. So I wanted to have Brian come on and talk about what his experience has been, and then maybe we can answer some questions after that. So Brian, thank you for joining us. How are you doing today? Or maybe he's not here. Or maybe he's on mute, maybe, I'm not sure.
Okay, thank you, Jason. Here can you hear me okay?
I sure can, yeah.
Great, I want to say thank you to you, and thanks for letting me speak today. I also want to say I need to give a bunch of thanks, but thank you for putting the picture of the facility up there. I mean, I was going to be afraid that you had a picture of me, and I must say Tracy Murray is much more better to look at than myself. So thank you for putting the facility up there. Sure. Going back to Tracy and Generations Healthcare, I want to say thank you to Tracy for being a leader herself. Sharing her experience. I'm sure it wasn't easy, and so thank you to her and Generations Healthcare. Thank you to the team that I'm able to work with day in and day out here at Tampico. Tracy mentioned that she had a dedicated go-to. She mentioned a person's name. I could spend this whole time talking about everybody, but I'm going to save that and just say that the team here is so important, and I thank them very much. Again, thank CAF, CDPH, also Contra Costa Health Services for the support that they've given us. We've also had a lot of outreach from the community. They have provided us, N95 masks. We've handed out groceries to our staff. They've supplied us with toilet paper and paper towels for their home use because, as you know, as of a month ago, it was so hard to get. The community really stepped up, and I'll talk about that in a minute. Lastly, before I continue, I want to thank the owners. I work with 2 owners here. We're a single entity. We also are a union building, and the owners have given me a flexibility to operate the facility to allow us to do what we do here. So One last thing, I want to start with, I have no disclosures. I will mention some names. I'm not paid by anybody. I'm not paid by CAF. I'm not paid. I'm paid by the facility, obviously, that I work from, but I have no other engagements or agreements. So just wanted to clear that up. The first thing I want to talk about is before I get into, there's 3 topics I want to talk about before I get into setting up the unit and how that went about. The first thing that I would recommend to everybody is that if you have not already immersed yourself about COVID-19 or SARS-CoV-2, now is the time. I've heard of other facilities that are just kind of dipping their toe in the water, so to speak, but you really need to just, if you think it's a bath of ice water, you just need to just jump in there and really learn everything and anything. There's so many resources out there. There's almost too many resources out there. I mean, I'm sure your email is just like my email. You're getting everything from all different directions. What I've done is I've created a document with all the science-based research articles, whether it be from anything on YouTube, anything from Ignites, anything from Leading Age, American Heart Association, ACA, obviously CAF, Cal TCM, big shout outs to them for providing us the information. But I set up a document where I can share it with the staff here at Tampico. I also put my test. I did the test about 2 weeks ago. I videotaped the test. I was allowed to videotape the test. I put that on the document as well. And so it's an active document. So instead of, if they catch themselves into the news of the local news, not to say that the local news is bad, but at least they can refer to something that's more science-based. And so my first point is really immersing yourself with everything that you could learn about COVID-19 and about the virus. Where that helps is because, Jason talked about with Dr. Wasserman about communicating with your staff. What I've done is I've created so far about 5 different in-services, and I just walk out with the in-service sheet, and then after the in-service sheet to sign it, I put them on electronic documents so we can see how many people we've been talking to, and if they don't have an X by their name over a certain course of time, we know that we have to talk to that employee. I've talked to everything about donning and doffing, obviously, about PPE. I'll walk around with a tub of PDI wipes, and I have, we've walked away from the normal, get as many of the staff as you can into a room. We've really kept it to only about maybe 4 to 6 people in a room, have them spread out. I've given them, a PDI wipe, have them power down their phones, have them wipe down their cell phones. And as they do this, we just pick a topic. What do we want to talk about? How do we educate them the best we can? Because I believe that giving them the knowledge, they will in turn be able to protect themselves better and hopefully not bring into the building. The second thing I wanted to talk about is using each other. When I say using each other, I mean using who you thought maybe was your competitor down the street. But I must say that I've talking to of my local buildings around me, Stonebrook, Manor Care, Danville, Post Acute. Really reach out to them, bounce ideas. You even may share PPE resources with them. You may just have a question. Like I said, I'm a single entity. Of course, I can turn to CAF, I can turn to all. But if I need to contact someone and I know their cell phone number or I know their building number, I can just call them at the drop of the hat and just ask them a question or say, hey, can I borrow a box of hair bouffants and I'll give it back to you in 2 weeks when my supplier says like he can give them, they can give them to me. Okay. So the third thing I want to mention before I get into how we set up the wing is talk about funding. If we, a lot of us, if you were fortunate enough to get the PPP, hats off to you. HHS, thank you very much. That was wonderful. We have the 10% Medi-Cal increase retro back to March 1, going through the pandemic. Those are all wonderful things. But if you have a platform to talk and to urge other people that we need more funding, we definitely need it. Jason talked about testing. Who's going to pay for that? How like I said, we are a single entity. Our census has been down, just like I'm sure a majority of others. I've talked to a facility, they were 30% down at the end of March and carried most likely probably all the way through April and now all the way through May. How are we going to pay for all this when our revenue has been down over the past 3 months? So those are things to ask for. Also on the funding side, we told you that one of the things that we've done for our staff is we provided them groceries. In the month of March, April, and May, once a month, we'll go out, we'll get the hard items to get: paper towels, toilet paper. This is not for in the facility. This is for outside. This is so they don't have to wait in line. It's easy for them. It's limiting their exposure to outside. We're not going to continue it. We'll try to think of something else we can do to support the staff. We've made our own hand sanitizer. Again, not for the facility. We have used some for the facility, but mostly to protect the staff outside of the facility. When they go to Costco, they go to a grocery store, they go to the gas station, we give them hand sanitizer. Actually, don't use a hand sanitizer when you fill up at the gas station. That's highly flammable. But we've given them gloves, we've given them masks, all these different items that we've given them just to show them that we care about them. We also care about our residents, we care about our patients, we care about the facility, and that we do these things so that they understand of how important it is. We're essentially doubling down on our staff. And I think if you can do that, if you can show that you care more than ever, I don't think you're going to have trouble getting them to work in your COVID wing, outside of worrying about lawsuits and labor laws and things like that. I think it's a lower cost item to be showing them that you care and the different ways that you can show them than having to work calling a labor attorney up. And no offense to labor attorneys out there, but caring for them. Okay. So let's go to how this started. I sorry that took a while. The referral came through just like any other referral. We were saying yes. Prior to this, we were burning through PPE for employees' understanding, because we knew that they can watch a video all they can, but unless they actually did the proper donning and doffing, they wouldn't be able to get the hands-on experience. And back then, we were learning that a lot of the exposure was because of the inaccurate or the I don't know if you use if the word is inappropriate, but not following the proper procedures on how to take on and take off the PPE. So prior to that, we were going through a lot of training, and then we got the referral, and we said yes to referrals. And as referrals go, some come, some don't. And finally, on a Friday afternoon in April, we got the go-ahead that this patient was coming. And so we had set up, we had to act fast. We had to set up the wall. We set up a visqueen wall in the hallway with a zipper. And that provided a safety for the staff, provided that nobody was to go in. And it was also a communication tool. Nobody goes in between. Nobody goes back and forth. Once you're in, you're in. You have to go home after that. There's no going back and forth in between. You can come from the regular unit into the unit, but you can't go the other direction. We had to figure out all the supplies and all the equipment. We knew we needed, in addition to the trash receptacles, we needed 3 other trash receptacles: one for linen, one for garbage in the room, and then one for garbage outside of the room when you take off your PPE. You needed shelves outside of the room, so when you wipe down your face shields and you have to put away your N95 to put on a regular surgical mask, you need a space to do all these things. You have to have extra space to put hand sanitizer and access to a hand washing sink. We actually took a room that was a resident room, and we turned that into the break room slash room for the staff where they can wash their hands, keep their supplies and things like that. And then when they exit the facility, they go out of that room as well. The challenge, the small challenge was probably the equipment, pulse oximeter, blood pressure, things like that, where you were in a facility communal, you're using that, you're wheeling it into each of the rooms, and then having individual ones for each of the COVID patients that you're taking care of. However, the biggest issue, if it's one thing that I can say, is to get everybody on board. And as much as I would like to say that we got everybody on board, including the management, we didn't. But however, we're still together. Knock on wood, nobody has left the facility due to opening up this wing. We did have some people take a two-week leave, but they came back. Did we provide hotel rooms? Yes, we provided hotel rooms. We provided about two rooms to 2 staff for about 3 nights each. After their first week, they didn't want to go back. They understood that it's probably, if you can proper don and doff, and you have good hand hygiene, you're probably much safer in that unit than any other unit throughout your facility. It is, and I must say for myself, I probably worked the first few days. I was in the facility probably for 2 days straight, just making sure that I can watch all the staff. And I probably could have delegated, but I felt more comfortable, being able to watch the staff put on and take off and watch their interactions, because for as much as I wanted the resident and the patient to be safe, I also wanted the staff to be safe. I wanted to make sure that they knew what they were doing. What else? We're getting close. I do want to leave some questions, some time for questions. One of the things that really was difficult for us, Jason mentioned about the morale. What provides, I think, a low morale is the uncertainty. And I'll give you an example of the uncertainty is back in April, part of the directive was that you had to be quarantined for 14 days. Should you be caring for COVID positive? And that has changed since then. And so that uncertainty in the directives that we hear from the different agencies and how it changes, that's difficult. And so when I was going back to, and I'll end with this, when I talked about immersing yourself and knowing as much as you can, when you have that knowledge, or at least you're confident with it, you try to go a step above of what's being required of you. What example can I give you that? As we go into phase 3, I believe one of the requirements is that we have to show a document, the county has to show a document that skilled nursing facilities have a 2-week supply of PPE. When I talk about going above and beyond, who says we have to limit ourselves to 2 weeks? Why can't we go to 3 weeks, or why can't we go to 4 weeks? Okay, I understand that's difficult, especially with how hard it is to get certain items. But that's what I'm talking about as far as being a step above of what's required of you. And I think if you do that, you'll fare well. And I wish, again, I thank CAF for the opportunity. I wanted to leave 10 minutes for questions, if anybody has questions for Jason or myself.
Thanks, Brian. That's fantastic. I just have one question. When you guys were identified as a space that could take COVID, did you get feedback or any media attention after that?
That's a great question. So the feedback, we worked closely. The local hospital and the county worked hand in hand. Before we admitted the patients, we obviously had to go through them. we had a doctor to doctor call outside of a nurse to nurse call. For those that do nurse to nurse calls, I mean, I'm sure there's some that do MD to MD. So that helped a lot. Once the media got wind of it through the CDPH website, I was reached out by the Chronicle via phone, and they asked me 4 questions. I forgot what those 4 questions were. I made myself available, and but they didn't reach out to me after that. Maybe they weren't happy with my answers. So you know.
Well, that's better than misquoting you or putting something else in there. So I want to thank you immensely. And Courtney, do we have any questions from the audience?
Yeah, we have a few. So I will start from the top here. So someone asked, could CAF please advocate for government testing of in-house collected samples?
Yeah, that's, I mean, our entire goal, we told them, look, Santa Clara's got this figured out. It's at least, the process and the logistics of it. Why can't we model this and do it across the state? Whether it follows their model or another model, but an end-to-end solution where the testing is brought to us or the test kits are delivered to us and we're taught how to do the test collection, and we send it to a lab and everything is internally managed. It sure would make it a whole bunch easier. I mean, vastly easier. The problem is that's not going to happen. Or if it is, it doesn't sound like it's on the board for them to do. I think the CDPH is really kind of stuck with, they want to give the local health departments flexibility. They don't want to mandate anything, even though this is really just a mandate, but they want to do that. I think there's some business folks out there that rather than look at this as an expenditure, they may look at it as an opportunity. These testing labs are getting paid lots of money to do this. Is there a portion of this where we can be that process? You individually can be that process. When I go to my doctor's office and they send me down to the lab downstairs, I don't see a bill, I don't see any of that. So how does that work? Can we do that same thing? I'm sure that there are smarter people than me out there that are doing this exact thing or doing something like that to make sure not only are they meeting the intent and fulfilling the mandate to do the testing, but they're doing it in a cost neutral or a cost benefit way. I don't know how that works, but I'm aware of folks with some creative ideas. I'm not going to give out business secrets on the phone, on the webinar, but I think the opportunity is there for you to look at this in a creative way. I hope that answered your question. If you're waiting for an end-to-end solution, unless you're in one of those counties that is doing that, it's not likely to occur from the state. Next question.
Okay, are there any indications that testing recommendations will follow for the ICF model? If so, do you think the recommendations will be similar to SNFs?
I don't think so. At this time, there's been no talk of that either nationally or at a state level. Doesn't mean that we wouldn't recommend you to have your staff tested. It just means that there's no specific requirement to do it. I will say this, I don't disagree that we need to do frequent staff testing. I'll say it's a primary driver of how this comes into your building, and it's the #1 thing that we can do to protect the life safety of the people in our building now, both staff and residents included. So it is important. I still think it's important if you're working in ICF, it's just not mandated. All right, next question.
Yes. Regarding testing of staff, since it is a strong recommendation from CDPH, can we expect that an employee's insurance will pay the cost?
Yes.
Additionally,
Go ahead. Well, we do know the CARES Act has basically said that all health plans have to pay for this, no deductible. You don't need a doctor's order to get the test. It's just a logistical process and the operational process of how do we do the tests, where do we send them, things like that. Like I said, the how you're going to do this is going to be highly dependent on the county in which your facility is in. Was there more to that question, Courtney?
Yeah, the second part was additionally, the Department of Managed Care has stated that testing is paid by the plans. Will this include all testing that will be performed, even though it will be frequent? Do you foresee any denials?
Well, they're not supposed to be. That was pretty specific. It's not just one test, it's ongoing testing and with no doctor's orders. You don't have to be symptomatic. None of that. At least that's the information that we got from the DHS, was that these folks, all the tests are covered in perpetuity for as long as needed. But the question is, well, that's great. The health plan is going to pay for it, but are we a part of their network to send them bills? And then your billing department or your billers are going to have to retrain themselves on how do they bill people's individual insurance companies for this, and tracking that and keeping records and then providing the test results to the thing. All of that is kind of combined into that logistical piece that's going to be really hard for you guys to operationalize. Next question.
Okay. Yeah. Can you give some advice for actual proper monitoring for those who are new in the position being a DSD/infection control?
That is a big question, and it's more than I can answer in 3 minutes. But what I will do is I will say that we have a couple of great clinical folks that work at CAF, one of who was both a DSD and an infection preventionist. And I highly encourage you to reach out to her, because you may need more than 3 minutes of kind of in-servicing. And Patty is great. She knows this stuff back and front. So I would give Patty Owens a call at the CAF office, or you can email her at powens@caf.org. And she'll be able to kind of walk you through the process. But that's a great question. I wish I had more time to go over all that stuff. Okay, next question.
What are we to do with staff refusing to be tested?
I don't know. Like I said, CDPH seems to think that you can fire these people. I'm not an employment attorney. I have no idea if that's actually true or not. I was not able to find anything in Title 22 that said that they were required to get this test, or required to get testing at the direction of CDPH. Now, I think a local public health officer can issue a health order, and that health order stands, and that's kind of you've got to do it. As it stands now, CDPH has kind of left it in the gray area, and they hope you guys can figure it out. And like I said, that's going to be an issue. We're going to have to talk to an employment attorney to ask you what your rights are and whether that's different in a union building than it is in a non-union building. All right, next question.
We have received feedback that there will be a change from 14 days to 28 days for COVID positive residents to be in isolation. Have you heard this?
No, I have not heard that. And I would be surprised if that changed. I know there's some concern that maybe there's a contagious period even after the 14 days. I know they changed it from 10 days to 14 days simply because they were still discovering that those folks in that 10 to 14 day range could potentially infect other people. And I actually think there are specific cases of that happening. So they changed it to 14 days. But I don't know if they're going to go past that 14 days. I have not heard that. And if they do, it doesn't seem consistent with what we see nationally from the CDC. All right, next question.
Let's see. Does it matter which test we do, which test we perform for staffing? Does it only have to be the RRT PCR testing?
Yes, PCR testing with 95% or above specificity. So if you have like an ID Now machine, or you want to go out and buy one of those, I don't think those meet the requirement yet. So that may come, and maybe the efficacy or the accuracy of those types of testing systems will meet that metric at some point, but right now, all they're saying is the PCR test. That's it. All right, next question. We got time for one more, I think.
Are you able to discipline an employee who did not inform administration of a positive test and then tried to lie about it once it was discovered?
Well, I don't know what the law says, but I would fire that person on the spot. That's not somebody I want in my building because they literally could have killed people. So that's like bringing a blowtorch into a gas station. It's just not what you do. Yeah, I don't know what the employment law says, but certainly that would be cause for termination in my book. So, all right. I want to thank you guys. I hate to end on a bummer of a note, and I know Brian got in here and thanked folks, and I have been remiss to thank the two people that make this happen every week, and that's Courtney Kesterson and Jamie Meamber. Been fantastic. You guys don't see this, but I am a Luddite when it comes to running webinars and the technology behind it. So they make this happen every week, and I want to say thank you from the bottom of my heart, because I get panicked and I get anxious and I get all those things if things don't go exactly right. So thank you very much. And as a wrap up, I just want to say thank you to every one of the providers out there on this call. We appreciate you greatly. If you have questions, please don't hesitate to reach out, and especially in the weeks when you start to get these mitigation plan reviews, let us know the feedback you're getting. And the person that left that forum note with specifics of questions that the surveyors are asking when they review this, that's great feedback, because it's stuff that other providers will need as they go through their own mitigation plan. So like Brian said, we may be in an island from CDPH. They're creative and thinking of good, sound clinical guidance, but in terms of physical help, that's going to be us and the local health departments are how that's going to happen. So help each other, share information, reach out to us with issues, and don't hesitate to call us if you have any problems. So I want to thank you very much. Have a great weekend. Take care.